Today's presentation is Potency of Platelet-Rich Plasma for Chronic Low Back Pain. It is a systematic review and meta-analysis of randomized controlled trial. As we all know, chronic low back pain is defined as pain which lasts at least one day, localized
Dr.
on the
Shveta, you can switch over to full screen. Just go to the in the bottom and right click. You can switch over to on the right side. From you can switch over to PPT mode on the right side. Just अरे वो तो zoom हो गया.
Not clicking the Zoom. Go to the PPT.
Not PPT.
Not PPT.
And then you see in the notes, comments written. At the
Just
end of
your
the PPT.
yeah,
Keep
more
going
on
to
the right side. More right. More,
next
next.
Next one. This one.
This.
Yes. Yeah. Great.
Low back pain is defined as pain which lasts at least one day, localized on the posterior aspect from the lower margin of the 12th rib until the lower gluteal fold. Low back pain patients require extensive multidisciplinary and multimodal care. Low back pain symptoms can be caused by a variety of anatomical issues like nerve roots, muscles, bones, joints, intervertebral discs, facial structures, and abdominal organs. Now, chronic low back pain is a leading cause of disability worldwide. Conventional treatments give limited or short-term relief. PRP is a regenerative therapy which is gaining interest. A short note on the history of how PRP was first used. So PRP was first utilized in an open heart surgery in the 1970s, and then 10 years later, it was used in maxillofacial surgery to help in wound healing in reconstructive jaw surgery. Regarding the mechanism of action of PRP, PRP encourages tissue angiogenesis and the mitogenesis of healing cells and contains 7 essential proteins, which include platelet-derived growth factor, transforming growth factor, vascular endothelial growth factor, epidermal growth factor, adhesive proteins like fibrin and fibrinonectin, and vitronectin. These supports 3 phases of tissue healing and repair cascade, such as inflammation, proliferation, and remodeling. Despite regenerative effects, PRP also has anti-inflammatory and anti-apoptotic effect by strengthening chondrogenic markers and inhibiting catabolic pathways. The objective of this study was to evaluate the efficacy of PRP injections in chronic low back pain. This was a systematic review and meta-analysis of randomized trials. The methods used included PRISMA-guided systematic review. Databases included PubMed, Medline, ScienceDirect, ProQuest. It included randomized controlled trials only, and the outcome was assessed on the basis of VAS pain score, disability indices. So as we can see in this flow diagram, that 144 records were identified through database searching, out of which 79 records retrieved. After that, 9 articles assessed for eligibility, and finally, 3 eligible studies were assessed qualitatively. And the follow-up was done at 1, 3, and 6 months. Now, quality assessment and bias assessment was done through identification, selection, data extraction, and quality assessment carried out independently by 2 authors. The difference of opinion between 2 authors were settled through conversation and re-evaluated with the 3rd author. The analysis of literature was evaluated with the Gedard scale, and to assess the risk of bias, the reviewers rated each of the 5 items into a dichotomous variables, that is yes or no. An overall scale was determined by adding all the scores, and each article was given a grade to indicate whether it's a high quality study or a low quality. An assessment of level of evidence was performed using the Oxford Center for Evidence-Based Medicine Guidelines 2011. Data were extracted from the tests, figures, tables, and related additional files from each included study. So these details comprise the article and demographic information, the kind, amount, and length of PRP intervention, and the clinical outcome. The results were also shown using forest plots on the data, and additionally, a funnel plot was employed to evaluate the publication bias significance, which was determined as p-value less than 0.5. So this is what the scale was used, and like we can all see here, 5 points were used, whether the study was described as random, randomization was appropriate or not, whether it was double-blinded, and the method of double-blinding was appropriate or not, description of dropouts and withdraw, whether it was there. And this is actually yes or no dichotomous variables where it was rated. Then the characteristics of the 3 studies is shown in this table. And intervention and outcome of the included studies is shown in this third table, where site of injection of PRP was different. In one, it was the lumbopelvic ligament, other was epidural and then intradiscal. Amounts also varied slightly, but the outcome was more or less similar, that improvement in pain scores was seen. The results were that PRP significantly reduced pain compared to control. Benefits were seen at 1, 3, and 6 months. There was improvement in disability scores and better functional outcomes with PRP at later follow-up. In this table, we can see that the assessment was done on the basis of pain, function, and safety, and there was significant improvement at 1 month, 3 months, and 6 months. Finally, in the discussion, the results of the current meta-analysis discovered that PRP demonstrated superiority in pain reduction in patients with low back pain compared to control. Now, there can be several underlying mechanisms by which PRP injections could lessen pain and enhance function. The concentration of platelets in PRP is 3 to 8 times than that in the serum. So this can be the result of this, that anti-inflammation, angiogenesis, cell migration, and anabolic metabolism for tissue repair and regeneration occurs. When platelets are activated in PRP, numerous growth factors like TGF-beta, platelet-derived growth factor, insulin-like growth factor, basic fibroblast growth factor, and many more can be released. They can stimulate chondrocytes and collagen 2 synthesis, prevent chondrocyte and mesenchymal stem cell apoptosis, and avoid catabolic effects of inflammatory cytokines. PRP also contains a plasma protein which is recognized to play a vital role in healing processes in connective tissues, and their impact on increased osmotic pressure through aggregants plays a major role in water absorption as well as providing tensile strength and anchoring the tissues to the bone through increased collagen. PRP injection surpasses the nuclear factor K beta signaling pathway and modifies this pathological condition to an anabolic and anti-inflammatory state. Regarding the safety profile, no serious adverse effects were reported. And since it is an autologous therapy, so immunogenic risk is also very low. These were the different targets which were used. Now a short comparison of PRP versus steroid injections. PRP is a regenerative delayed onset therapy, longer lasting benefits, while steroid, although rapid onset, is short-term relief. PRP may modify pathology, but steroids provide only symptomatic treatment. And PRP, being autologous, is very safe, while steroids do have a risk with repeated injections. This is a short summary where PRP and steroids have been compared regarding different parameters. Mechanism, we understand PRP is regenerative, steroid is anti-inflammatory. Onset of action of PRP is delayed. For steroids, it is rapid. Duration of benefit for PRP is months, while for steroids, it is very short. Effect on the disease pathology is that PRP may modify the pathology, while steroids provide only symptomatic relief. Safety of PRP is comparatively much higher than steroid, which have repeated use risks. And evidence strength in case of PRP is emerging mixed because it is still under a lot of research, while for steroids, it is a well-established short-term benefit. Now, the limitations of this study were that small number of randomized control trials have been conducted. There could be heterogeneity in PRP preparation and hence the results varied. Different injection targets were used and the duration of follow-up was short. But still, as evidence summary, PRP shows significant short-term benefit. Functional improvement was reported, but overall evidence quality still remains low to moderate. The clinical implications of this study could be that PRP could be considered in selected chronic low back pain patients. It should be used after failure of conservative therapy, and it's still not yet the standard of established care. The discussion points for the topic may be whether we are ready for PRP use, which patients will benefit most, and PRP versus steroid, when to choose which. PRP works biologically, not as a painkiller. It has a delayed onset but sustained benefit. Best results in discogenic low back pain. Patient selection is critical, and still it is not a replacement for surgery. Thank you.
Great. Thanks, Dr. Shveta. Dr. Nitika, you can share your screen and we'll have discussion together at the end.
Yes, ma'am. Ma'am, is my screen visible?
Yes.
Good evening. I'll be presenting evidence-based clinical practice guidelines on the use of regenerative medicine for chronic pain. This is a consensus report from a multi-specialty working group, and it was published in Journal of Pain Research in the year of 2024. So what is regenerative medicine? It is basically harnessing the body's innate healing capacity, which includes injectable biologics, including platelet-rich plasma, mesenchymal stem cells, and bone marrow aspirate concentrate to restore the tissue function and reduce pain, and thus improving the quality of life. The evolution of regenerative medicine started way back in 1930 when prolotherapy first emerged. It laid the foundation of early foundational concepts in regenerative therapies, focusing on injective solutions to stimulate the tissue repair. Thereafter, in 1957, there was first hematopoietic stem cell transplantation was done, which was a landmark medical achievement, paving way for cellular therapies, understanding stem cell potential. Thereafter, platelet-rich plasma development came in 1990s, and more recently, there is identification of the use of mesenchymal stem cells, which have opened novel therapeutic avenues with their multipotent differentiation capabilities and immunomodulatory properties. Despite the growing clinical adoption and there is inconsistent practice patterns and variable trial outcomes, which have hindered the broad acceptance by various regulatory agencies and payers. The various injectable biologic agents which are currently being used include platelet-rich plasma. This platelet-rich plasma, as we have already studied, it is basically a supraphysiologic concentration of platelets, which is rich in various growth factors, which include epithelial growth factor, insulin-derived growth factor, platelet-derived growth factor. Then second is the bone marrow aspirate concentrate, which contains hematopoietic stem cells, endothelial progenitor cells, and mesenchymal stromal cells, which have regenerative potential. Then there is adipose-derived biologics, which include heterogeneous cell populations, including mesenchymal stem cells, regulatory T cells, and pericytes, obtained through liposuction and processing. And then there are mesenchymal stem cells, these are the cells which are capable of differentiating into mesodermal lineage tissues, and they express various CD markers, including CD105, CD73, and CD90 markers. So how the regenerative medicine actually works? It leads to cytokine release. It releases various anti-inflammatory cytokines, which create a favorable microenvironment for tissue healing and pain reduction. There is growth factor secretion, including vascular endothelial growth factor, platelet-derived growth factor, transforming growth factor beta, which stimulates angiogenesis and cellular proliferation. And there is macrophage polarization. The monocytes, they differentiate into M2 anti-inflammatory macrophages, which modulate the immune response. And there is extracellular vesicle formation, which perform paracrine functions, mimicking progenitor cell therapeutic effects. So how these consensus guidelines, they were developed? The American Society of Pain and Neurosciences commissioned an international multi-specialty panel which consisted of anesthesiologists, pain medicine physicians, physical medicine and rehabilitation physicians, and sports medicine physicians who were expert in the field of regenerative medicine, and they searched various databases. And in their search, they included randomized controlled trials, observational studies, case series, and preclinical mechanistic data. And initially, out of after studying about 8,256 studies, they finalized about 740 articles, which were used for the development of these guidelines. So, using the modified Delphi approach with the international multi-specialty panel, after achieving more than 80% agreement on all the recommendations, they created a pragmatic guidelines which address the mechanisms, indications, technique optimization, and safety concentration in the field of regenerative medicine in chronic pain. So they basically took 16 clinical questions which addressed the practical aspect of regenerative medicine, and they reviewed 740 articles, and finally they came to 49 consensus points which included comprehensive recommendations covering mechanisms, indications, techniques, and safety for the use of regenerative medicine in chronic pain. The United States Preventive Services and Task Force criteria, they basically graded these 39 consensus points into various levels of evidence, level 1, level 2, level 3, level 4, and various grades of recommendation, grade A, B, C, D, and I, grade I. So these 49 consensus points, they were graded according to these level of evidence and level of grades of recommendation. So the 16 questions I'll be discussing one by one. The first question was, what are the injectable biologic agents that are available for treatment of chronic pain conditions? So the commonly used, as has already been discussed, is platelet-rich plasma, autologous conditioned serum, bone marrow aspirate concentrate, adipose tissue-derived biologics, mesenchymal stem cells, amniotic-based products, extracellular matrix substances, extracellular vesicles, and recombinant bone morphologic proteins. The platelet-rich plasma is a concentrated plasma derived from the patient's own blood, which is rich in growth factors and cytokines, and it is prepared after using minimal invasive preparation, and it is rapidly available in the chronic pain clinic settings. Mesenchymal stem cells, while these are the multipotent progenitor cells, they can differentiate into multiple cell types. They have immunomodulatory properties, and they require a longer culture period for their preparation. Bone marrow aspirate concentrate, they are harvested from the patient's bone marrow, and they contain stem cells and growth factors, and they maintain native cellular environment. And they require a single procedure approach. So peripheral blood is basically a source of platelet-rich plasma, platelet-poor plasma, and platelet-rich fibrin, while bone marrow is a source of bone marrow aspirate concentrate, bone marrow aspirate, and hybrid bone marrow aspirate concentrate. Adipose tissue is a source of microfragmented adipose tissue, macroscopic fat tissue, nanofat tissue, and stromal vascular fraction. The cellular mechanisms I have already covered. They are all involved in immunomodulation, growth factor and cytokine signaling, cell differentiation, and paracrine signaling. So platelet-rich plasma is defined as a volume of plasma containing a concentrate of platelets above the baseline of typical or healthy blood levels. Concentration of platelets in platelet-rich plasma varies from 2.5 to 8 times above the baseline, or absolute platelet concentration of 10 lakhs per ml of PRP. PRP consists of various cellular and molecular components. The cellular components include platelets, mononuclear cells, hematopoietic stem cells, hematopoietic progenitor cells, and endothelial progenitor cells, while the molecular components include the growth factors and a variety of immune modulatory molecular proteins. So what are the different PRP preparations which are available? PRP can be either leukocyte poor or leukocyte rich, and while the platelet rich fibrin can also be leukocyte poor or leukocyte rich. Then coming to the another injectable biologic, that is autologous conditioned serum. This is a cell-free blood product which is derived from the patient's own blood, and it's rich in anti-inflammatory components, especially interleukin-1 receptor antagonist. In this, the blood is incubated at a controlled temperature of 37 degrees for several hours, often 6 hours, and it stimulates the production of anti-inflammatory cytokines such as interleukin-1 receptor antagonist. Then coming to the bone marrow derived products, there are bone marrow aspirate concentrate is obtained from the posterior superior iliac spine, and it is a concentrated form rich in mesenchymal stem cells, endothelial progenitor cells, and hematopoietic stem cells. It also carries megakaryocytes, platelets, growth factors, and cytokines, and collectively contribute to substantial paracrine effect, which enhances tissue repair and regeneration. Presence of these bioactive molecules supports cellular differentiation and proliferation, and it also modulates local inflammatory response and promotes angiogenesis. So this is basically a technique of a traditional approach of taking the bone marrow aspirate concentrate, in which the needle is directed from posterior superior iliac spine towards the greater trochanter. Now the novel approach that is preferred, in which the needle direction is directed towards the from the posterior superior iliac spine to the anterior superior iliac spine. Then there are other injectable biologics, which include the adipose tissue derived materials, which are obtained through liposuction and processing techniques. Macro fat and microfragmented adipose tissue provide structural support and cushioning. Nanofat and stromal vascular fraction are rich in various cells, such as adipose derived stem cells and mesenchymal and endothelial progenitor cells. So, what is the difference between the bone marrow derived mesenchymal stem cells and adipose derived mesenchymal stem cells? Bone marrow derived is harvest is easy to perform, while for adipose derived harvest is technically challenging. They require minimal processing in bone marrow, while multi-step processing is required for adipose tissue derived. The bone marrow have greater differentiation potential as compared to adipose tissue derived mesenchymal stem cells, which have lower differentiation potential. And there is high chances of scarring due to uncontrolled differentiation, while the amount of adipose tissue that can be harvested depends upon the patient's size and body fat content. The consensus point one was that the mechanism of action of injectable biologics are multifaceted and related to specific injected biologics. The common mechanisms I've already, as discussed, there is release of anti-inflammatory cytokines, release of growth factors, differentiation of mononuclear cells into anti-inflammatory macrophages, and release of extracellular vesicles. So the second question which was addressed is, what is the evidence basis for variants of standard platelet biologics? There is insufficient evidence regarding the most appropriate PRP product, whether leukocyte rich is helpful or leukocyte poor is helpful. There is no particular sufficient evidence available for any kind of pathology. There is some evidence supporting role of leukocytes in growth factor release. Several studies showing that leukocyte reduced, often platelet reduced products may not be effective. The third question which was addressed was, what injectable biologics are used in prolotherapy for treatment of chronic pain conditions? Prolotherapy, as we know, is a form of regenerative medicine where non-biologic agents are used to stimulate inflammation and growth. Some non-biologic agents utilized in prolotherapy include hypertonic dextrose, phenol, glycerine glucose, sodium morphate, and pumice. Prolotherapy has primarily been utilized in research settings, and most commonly utilized is hypertonic dextrose, and with proposed mechanisms involving the generation of temporary low-grade inflammation followed by cytokine release that promotes growth and healing. The next question which was addressed is, what is the evidence for treatment of tendinopathies using injectable biologics? For lateral epicondylitis, PRP injection was associated with superior long-term relief as compared to the corticosteroid injections. There was limited evidence suggesting bone marrow aspirate concentrate and adipose tissue derived mesenchymal stem cell injection for lateral epicondylitis. While the intratendinous autologous condition plasma injection is likely ineffective for improving pain control or functionality in lateral epicondylitis and other tendinopathies. For medial epicondylitis, PRP injection may provide long-term relief and functionality as compared to surgery and tenotomy. For Achilles tendinopathy, there was inconsistent and conflicting evidence on the use of PRP and bone marrow aspirate concentrate. For plantar fasciitis, dextrose prolotherapy was found to be inferior to corticosteroid injection, while PRP was found to be superior and compared to the corticosteroid injection. In patellar tendinitis, there was inconsistent and conflicting evidence for the use of PRP and injectable biologics, and thus it was not recommended. For rotator cuff tendinopathy, PRP provided superior analgesia compared to corticosteroid injections with minimal concentration of 4 to 5 times in the PRP injected. And there was limited studies for bone marrow aspirate concentrate. For proximal hamstring tendinosis and gluteal tendinosis, there was also again inconsistent but promising evidence on the use of PRP. The next question was, what is the evidence for treatment of muscular pathologies with injectable biologics? There was limited evidence to suggest PRP with physical therapy is superior to just physical therapy alone. And there is current evidence which suggests that there is likely minimal to no benefit with PRP. The next question is, what is the evidence for treatment of osteoarthritis, osteochondral defects using injectable biologics? So PRP for knee osteoarthritis was associated with superior long-term analgesia, physical functioning as compared to hyaluronic acid, corticosteroid injection, and placebo at 6 and 12 months. And there was conflicting evidence on the use of mesenchymal stem cells for knee osteoarthritis. Intra-articular PRP for hip osteoarthritis also showed no difference when compared to other interventions like hyaluronic acid. PRP for shoulder osteoarthritis was found to be superior compared to the corticosteroids. Use of PRP and BMAC for osteoarthritis of foot and hand is not recommended. So coming to the next question, what is the evidence for full injectable biologics in low back pain? So PRP injections in the lumbar facet joint was found to be superior and as compared to local anesthetics and corticosteroid injections. And there was limited evidence with bone marrow aspirate concentrate. Intra-articular sacroiliac joint injections with PRP was also found to be have superior analgesia compared to the intra-articular corticosteroid injections, and there was no study found for mesenchymal stem cells or bone marrow aspirate concentrate. Intradiscal PRP BMAC concentrations led to improvement of discogenic pain compared to placebo, corticosteroids, hyaluronic acid injections. And there was limited evidence with intradiscal stromal vascular fraction. The intradiscal bone marrow aspirate injection may provide long-term alleviation of pain and improvement in physical function in patients with discogenic pain. So what next question was, what is the evidence for neuropathic pain? There was limited evidence which suggested that perineural injection of PRP along the nerves in diabetic peripheral neuropathy could be superior compared to the conventional medical management. Limited and conflicted evidence also suggested that intrathecal or intralesional injection with mesenchymal stem cells for spinal cord injury, chronic pain is not recommended. So basically, there is no role of mesenchymal stem cells in chronic pain due to spinal cord injury. Epidural injection with autologous conditioned serum may improve radicular pain. There is some evidence that it is not superior to corticosteroid injection. Then epidural injections with PRP or other PRP-related products may alleviate the radicular pain. Intradiscal injection with mesenchymal stem cells or plasma lysate may alleviate radicular pain. Then what is the evidence of biologics for trigeminal neuralgia? The perineural injection at trigeminal nerve with biologics is currently not recommended. Evidence for postherpetic neuralgia, autologous fat graft injection at the site of pain for postherpetic neuralgia is not associated with superior analgesia compared to placebo. PRP at site of pain for PHN as an adjunct to oral neuropathic analgesics may be associated with improved pain intensity compared to the medications alone. So what is the role of injectable biologics in surgical augmentation? In rotator cuff repair surgeries, PRP, growth factors, mesenchymal stem cells, exosomes have been explored to enhance healing in orthopedic surgeries. Preclinical studies showed improved histologic and biomechanical outcomes. Clinical results, however, are inconsistent. PRP application at tendon bone junction has not reliably improved healing re-tear rates in clinical trials. Novel delivery methods may improve local retention, but they lack clinical validation. Mesenchymal stem cells biologic grafts show promise in preclinical rotator cuff studies, but robust RCT evidence is limited. In Achilles tendon repair, augmented with PRP and other biologics show variable clinical benefits. Combined biologic approaches offer synergistic effects in Achilles tendinopathy, but evidence remains preliminary. For ACL reconstruction surgeries, PRP and mesenchymal stem cells may aid graft maturation Yet consistent improvement is lacking. There is no clear reduction in re-rupture rates or superior graft integration that has been demonstrated in ACL reconstruction. In meniscal repair or regeneration surgeries, meniscal repair has a failure rate of up to 24%. And PRP use in meniscal repair surgeries, they show conflicting results due to heterogeneity in preparation and study design. Mesenchymal stem cells and bone marrow aspirate concentrate they demonstrate mixed and dose-dependent outcomes. In core decompression with BMAC for early stage avascular necrosis of hip, it has been found to lead to improvement in pain, function, and reduced THR rates. Long-term studies suggested superior outcomes of core decompression plus BMAC compared to core decompression alone. And there is benefit of biologic augmentation are not seen in post-collapse AVN of hip. Most studies across orthopedic applications are small, heterogeneous, and methodologically limited. The current evidence is inconclusive, and routine surgical augmentation with injectable biologics is not recommended. What is the dose and concentration of injectable biologics which is necessary for therapeutic efficacy? Platelets and mesenchymal stem cells dosing show wide heterogeneity across studies with inconsistent implementation of reporting standards. For rotator cuff pathologies, the effective PRP dose ranged between 2 to 6.75 billion, while for shoulder osteoarthritis, it was between 3.1 to 9.3 billion. For adhesive capsulitis, it was 1.7 to 7.6 billion. Hip osteoarthritis, it varied between 7 to 8.4 billion. Epicondylar tendinopathy, it varied, the effective dose was approximately 1 billion platelets. So there was wide range in the dose of the platelet-rich plasma for various pathologies. For mesenchymal stem cells for knee osteoarthritis, the dose was around 40 200 into 10 raised to plus 6 cells. That was found to be most effective. So evidence is insufficient to define the optimum dose, concentration, or volume of injectable biologics, which was showing maximum efficacy. What is the role of culture expansion of stem cells? Bone marrow is the most common source of mesenchymal stem cells in clinical trials. The culture expansion of mesenchymal stem cells is complex and regulated under Section 351 of Public Health Services Act. FDA classifies the culture expanded mesenchymal stem cells as high risk product requiring stringent pre and post market approval. So culture expansion is considered more than minimal manipulation, and therefore it is not legally permitted. Currently, US clinical practice primarily involves same-day bone marrow aspiration, centrifugation, and injection. Bone marrow aspirate concentrate complies with FDA regulation as it involves only minimal manipulation of cells. Adipose-derived stromal vascular fraction products involved enzymatic processing generally considered more than minimal manipulation. So ongoing legal challenges may influence future regulatory oversight of stromal vascular fraction based therapies. Culture expansion of mesenchymal stem cells is not permitted, remains subject to strict federal regulation. How do injectable biologics compare with each other in terms of efficacy for treatment of chronic pain? Chronic knee osteoarthritis is the most studied indication, and PRP and BMAC are the most commonly studied injectates for knee osteoarthritis. And strong evidence supports properly dosed PRP with most RCTs. They showed superiority over hyaluronic acid, salines, steroids, and exercise. Bone marrow aspirate concentrate also shows promising results in multiple RCTs in knee osteoarthritis. Long-term follow-up studies support both intra-articular and intraosseous BMAC techniques. PRP and mesenchymal stem cell-based therapies show no clinically significant difference in pain and function for knee osteoarthritis. What peri-procedural best practices are recommended to optimize response to injectable biologics? NSAIDs, aspirin should be withheld for 4 to 5 times their half-lives prior to the procedure and at least 4 to 8 weeks post-procedure. Natural supplements, naturopathic agents should be withheld for at least 1 week, and time frame to resume these medications depend upon the clinician's discretion. Insufficient evidence to suggest holding or discontinuation of DMARDs during peri-procedural period. Weight-bearing activity limitation that limits stress on injected area is recommended for 2 to 7 days post-procedure. Use of orthosis crutches is recommended, may be used after injection of biologics for upper or lower extremity tendinopathy. Stretching and range of motion activities phase 1 is recommended within 2 to 7 days, while strengthening activities is recommended 14 to 21 days post-procedurally. What peri-procedure best practices are recommended to optimize the yield and quality of injectable biologics? There is insufficient evidence to make reasonable conclusions regarding the hydration. So it is not basically the hydration may not improve the yield of the injectable biologics. While topical infiltration of local anesthetic is reasonable during procedures, avoidance of local anesthetic directly at the site of injection is recommended, as this can be cytotoxic to the biologic injected. Tobacco and alcohol use have demonstrated cytotoxic effect within in vitro study and may reduce platelet aggregation. So it is better to avoid the tobacco and alcohol use. What are the ethical considerations and the regulations surrounding use of injectable biologic products? When injectable biologics are utilized in the clinical setting, they fall under the regulatory control of Section 361 of Public Health Services and Code of Federal Regulation, Part 271. According to this, only homologous use and minimal manipulation of the cells is permissible. No additions can be made to the product, and product should not have any systemic side effects. Then coming to the question number 16, what are the potential rare effects, adverse events which are noticed from the injectable biologic agents? Injectable biologics are commonly cause mild adverse effects such as localized pain, soreness, bruising, and transient symptom flare. Infection risk exists, particularly with poor sterile technique, closed processing systems, reduced contamination risk. BMAC may cause donor site pain, bruising, soreness, generally managed with conservative care. Adipose-derived cell therapies may result in cosmetic issues such as skin dimpling if aspiration technique is poor. Rare but serious risks include tumor formation, unwanted cell growth, disease transmission, and viral reactivation. Mesenchymal stem cells are relatively immune privileged but may become immunogenic after differentiation. Allogenic stem cells carry potential risk of immune reaction and graft versus host disease. So PRP and mesenchymal stem cells are generally safe, but rare side effects can occur with their use. Summarizing these guidelines, so these basically are the multispecialty guidelines which synthesize current evidence on injectable biologics for chronic pain, including mechanism, best practice, ethics, and adverse events. The consensus points were developed using the modified Delphi approach, achieving more than 80% expert agreement. Injectable biologics, they basically act by various mechanisms. The evidence remains uncertain due to heterogeneity in patient selection, disease severity, and biologic preparation. Future high quality randomized control trials with standardized reporting are essential to define the efficacy mechanism and optimal use. Thank you.
Thank you, Dr. Nitika, for beautifully elaborating this clinical practice guidelines on regenerative medicine. Sorry, I'm unable to open this video. Ashu, sir?
Yes.
Yes, sir. Sir, can you please add on to this presentation?
We don't have any experience in low back pain.
Yeah.
We have not used in low
Same
back
here.
pain,
Actually, I'm also using a lot of PRP and bone marrow for the
so
shoulder, knee, and
you are having a better
all the peripherals.
experience than
But
me.
sir, back pain, even I have not used till now. But I'm planning
Yes,
to use
back
this
pain
soon.
we don't have any experience.
Mhm.
Siddharth can tell if he has some experience. Siddharth is here.
Yes, sir.
सिद्धार्थ है आपका कुछ एक्सपीरियंस विद लो बैक?
So I don't use it in low back pain for two, three reasons. One is I can tackle most of the facet pain with RF, And second is for the discogenic pain, I'm scared about the infection.
Infection. Hmm.
And I have seen, I think, couple of people use it. Probably Dr. Diwan uses it a lot. But then I'm quite scared of using it in the disc.
So
So I don't
there is
do any intradiscal.
particularly mention about epidural use.
Actually, most of us are afraid of using it intradiscal, but the plasma lysate mixture that can be used epidurally.
What is
The
that?
same way, so
Yes.
basically
So
the growth factor
that I have used.
concentrates. Hmm.
So the I have used it in the emerald space. Now there the problem is that we need to give it multiple times. So I feel
And
single injection will not yield very good result. This is my clinical experience. I mean, others can add in. And I found that the patience with the results has to be really high. So if we explain properly and counsel, maybe in future it can be used. But definitely right now I'm not using it in
No, it is
any of the.
transforamen or interlaminar. Which
So
approach?
I have used in interlaminar also and transdermal also.
Acha.
actually, it can be used transforaminally using a proper filter so that we don't inject any cellular products there.
Acha. 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 It
It
is
should be used
only.
in that way. Even
Acha.
I
Acha.
haven't tried, but yes, I'll be doing it soon. And once I do, I'll
Hmm.
let you know.
Upgrade. Update
Yeah.
us.
Yes, sir, sure.
Us also. No experience at all.
Yes, sir.
So so the thing is, what indications you will use it matters a lot, because then we have a clinical practice. I work in private, so and I think most of us work in private. So it becomes very tough for us to kind of quantify or maybe tell them what will be the results like when if we are not confident. So probably I would like to wait a little more, and this should be used in institutional settings before it comes to probably common use.
Now, my
Yeah,
question will
just
be what are the indications like mild canal stenosis, moderate, whatever? Is there any specific guidelines
so
where to use
probably
and when not?
the HIZ types,
Acha.
annulatius,
So for
Okay.
facet
discogen,
joint
and facet
arthritis,
joints, yes.
especially in young patients, like patients in 30s, when they present with facet arthropathy, then I have used PRP, and that's like a common thing. I don't
Intra-articular?
intra-articular facet.
So
Yes.
how
Yes,
many times you use?
So
single
just
time.
one sitting, yes, one sitting.
Acha.
It gives a good relief, just 1 to 1.5 cc per joint for facet joint, especially L4-5, L5S1. And I've been using it since 2022, I
No,
guess.
suppose you are using this platelet in facet joint, you don't give steroid in that setting?
No, sir.
Only platelet.
Only PRP.
अच्छा जो routine
Even for the
PRP
transforaminal, sir, we don't use steroids. We use only the plasma lysate mixtures
अच्छा
without
अच्छा अच्छा
steroids.
हम्म अच्छा मतलब this is
Similarly,
what
for
I
the
want to ask actually.
SI joint and the facet, yeah,
Then there was a
but
mention of SI joint also. So is anybody
yes, sir.
using in SI joint?
The SI
So
joint,
SI
I
joint
plan to
actually
use.
I have used it quite a bit. So SI
Okay.
joint, the advantage is that even if you are periarticular, so it will give you good results. So
Single injection
the
again?
only thing is, yes, single. No, no, sir. I never use a single injection. I mean, facet के लिए भी I mean, never used it because I was doing RF, but sacroiliac I have used it. Only thing is, I have injected more amount in the ligaments, and
Okay.
since the joint volume is less,
Hmm.
and I have used it only in multiple sittings. So I always tell the patient for two sittings. The reason for that is that I mean, I have a clinical reason of my own that number one, it's uh, more effective to explain to the patient that you will have two sittings, and if the first one doesn't work, the second one we do the RF or something else. So patient is mentally much well prepared, and if you see the evidence also, so
Hmm.
single, this thing, the most of the people have mentioned that the effect of biologics is slow onset and long lasting.
Hmm.
So with a single injection, it becomes very difficult for me to quantify the effect if they don't come back
Hmm.
for the second time.
So second injection after 1 month, 6 weeks, what?
So for all my procedures, sir, I have a clear protocol of about 4 weeks. So
Four
earlier I
weeks,
was doing
right.
it in 6 weeks.
Mm.
But then gradually learning from all other colleagues, I
Mm.
reduced my time interval to 4 weeks now.
Yeah, so it is around 4 weeks, 2 sitting.
Yes, sir.
Okay, okay.
Sacroiliac joint pain, sir. Remember our first journal club when Dr. Dipinder presented like multiple articles together, and she just presented one. And the conclusions in many of the SIJ were that the pain doesn't come from the joint itself; it comes from the ligaments
Mm.
many a time. So I think that's the reason as
Yes.
well. Like, and it's hard to differentiate with the X-ray or like clinical examination. So Dr. Sidharth is right. Like if we inject into ligaments along with the joints, I think it just helps in the strengthening of the,
Okay.
and ligaments
So how I,
always require 2 sittings. Single sitting is.
And which ligament you choose and how?
sir, how I started was that we were any which ways doing the intra-articular and then doing a prolo also. And many
Mm.
people were combining the intra-articular with RF.
Mm.
So what we were doing is if we are doing an ultrasound guided technique, just the injection. Naturally, the ultrasound guided technique also has evolved over a period of time. So the first
Mm.
time when I was using it, we could never see the needle going in. It was just
Mm.
the shadow ke niche jata tha, so we used to give the drug. And then as the technique became more refined, now I can actually be a little more precise.
Mm.
So, to answer to your ligament is that the ligament question, I am not very specific about a particular ligament where I
Okay.
will be giving as of now. But
Mm.
maybe later on, if we can pinpoint the cause to that extent, then maybe we can do that. Dr.
Okay.
Achal, have you got any different experience?
Sir, I have not seen SIJ in young patients so far. So I only do cooled RF because most of my SIJs are more than 60s. But lumbar facet, I've started seeing very early in my practice for 30s and 40s. So that's why I got the chance to do lumbar facet, and I got the good results. So in people in 30s and 40s, if they present with lumbar facet arthropathy, then I do PRP. Raj sir, Dr. Raj, आप कुछ कह रहे थे? You were saying something about your.
I was just talking, if we have to do intradiscals, better to use BMAC rather than PRP.
Okay. Because of the like the infection
effective.
reasons or the more potential?
More potential.
More potential.
And we have got the
I feel the
mesenchymal
infection
cells,
will be the
results are
same.
different. Infection will be obviously same. Rate will be same.
Yeah.
So then you have to be very cautious, use a double needle technique and give a shot of antibiotic beforehand.
And where to inject? In the disc? In the center or in the L posterior annulus?
No, center is okay. I mean,
Achha.
hardly accommodate 1 ml. Sometimes, as you inject, there's a lot of pain. Maybe you can inject 1.5, 2 ml at the max, and then while coming back, maybe rest of it you can inject in the epidural space.
Bone marrow, it's aspirate itself causes a lot of stiffness afterwards. If you inject even in the supraspinatus tear or in the knee, it itself causes a lot of stiffness.
And the results are even slower than the PRP.
PRP, but the results are brilliant.
Yeah, and then it's very costly.
Dr. Ashu, I have done 2 bone marrow in supraspinatus, one for the supraspinatus tear and one for the ACL. Brilliant results, but yes, for the 1.5 month, for 6 to 8 weeks, basically 6 weeks, patients were after my life because there was so much of stiffness. But
Yes,
after
yes.
that, immediately the stiffness vanished, and they had very brilliant pain results, and they have started doing the supraspinatus wala to has started doing gym too. ACL wala is running, so very good results with the BMAC.
What were the types of injuries, Dr. Namrata, if you don't mind sharing that time for supraspinatus and ACL?
Supraspinatus has articular surface tear more than 75%, but non-retracted tender.
Okay, and the other one?
ACL was
ACL one?
also a little bit attached, or 50% tha.
And was there any associated meniscal injuries?
Yeah, meniscus was there. Medial meniscus, I treated that too. Medial meniscus in
Means
ACL.
So in the same, just by the injection, suprapatellar regular approach.
No, in the meniscus and in the ACL.
Okay, so you went into the meniscus and
Yeah,
LCL.
went into
And
the
what were the
meniscus
ages
and
of these
into the
patients?
ACL. Hmm?
What
Age?
were the age of these patients? Yes, yes.
Supraspinatus valla was around
Approximate,
50.
just for our
Yeah,
understanding. Yeah, okay.
um,
Yeah.
around 50, 45, 50.
Oh, good. And the other one, the knee one?
Both were of almost similar age.
Wonderful, because
Non-cardiac, non-hypertensive, non-diabetic, not on any
wonderful.
other medications. So I ruled out
Great
everything.
insight.
Only after
Great
that,
insight.
yes, I did this BMAT.
So usually, the challenge with, especially with knee patients, is that as the age advances, the surgeon is not ready to do arthroscopy because they feel that the results won't be appropriate, and the regenerative guy is also scared that maybe the results might not be appropriate because of the advanced age and poor regenerative capacities. But we need to, I think, learn from your case and your experience that even in
BMAT
advanced
had
ages
very good,
you can use
yeah,
it.
it had good
Yes.
results. BMAT had
So
good
I have a
results.
similar experience actually, even with PRP. So I felt that it was, although I've not used it in like 70 or 80 years, but then definitely I used it in 55 years or something. And
Yeah,
I didn't
70
feel
and
that
80,
there
so
was
even
much
I
of,
would avoid. Better to go for
yeah,
RF and other things. But yes,
yes,
up to
agreed.
60, I think, yes, regenerative, it has a very good potential. We can try
We should
that PRP in the
Metaanalysis.
younger age groups, and later we can do the BMAC. That will help.
Yes, I agree. Any experience about combining multiple techniques? Anyone, like for example, combining an RF with a
No,
BMAC
no,
or this thing?
no. We either do RF or either regenerative or the ablative.
Any reason for that?
No, just like that. I
Yeah,
don't know.
because I am combining both because the advantage, which maybe you can try in some of the cases. So the advantage which I feel is there is that initial pain which is taken care of very well by the RF, and maybe the delayed result is compensated, and by the time maybe you can reduce the initial discomfort of the patient. Maybe in some indications you can try
Basically, I
with.
thought if I do combine the RF with the BMAC, I will not be able to appreciate which thing is acting. Basically, I just wanted to see the result of the BMAC. So
Understood,
that's why,
understood.
yeah.
Plus, post RFA, would you not have to inject steroid, or that's not your practice?
So, post RF, I never do an intra-articular RF. So I'm always targeting the nerves around. And post RF, if I'm combining it with the, even if I'm combining it with PRP, I will always inject about 5 mg of triamcinolone at the after the RF.
Yeah,
Even with the PRP.
Yeah,
Like
but PRP I'm
PRP
going to give in the
intra-articular, you will
joint.
be doing
Yes,
intra-articular.
PRP
Okay.
I will go intra-articular, and the RF I am targeting, for example, the genicular nerves for the knee, for example. And if I will do a supra scapular nerve RF, by the way, I don't do the pulse radio frequency. I will do a 60-degree, 90-second, or 60-degree, 60-second standard RF for suprascapular nerve also.
In the
Uh,
spinogluteal
for
notch or the regular fossa?
the uh, the spinoglynoid notch.
Okay.
But there is, after the advent of this pooled RF technique, my that practice has reduced because now I can actually target the articular branches very nicely. Only in patients who cannot afford the cost, I will go for the single the earlier practice where I was using only the standard RF. PRF won't work for most of these patients.
Yeah.
Dr. Ashish also has joined. Dr. Ashish, your
Yeah, hi.
personal
Good
experience
evening.
with PRP or BMAC?
Not much with BMAC, but definitely, as Siddharth was pointing out, radio frequency along with PRP definitely has got very good results in lumbar facets. And
So you do
uh,
PRP in lumbar facet?
yes,
Okay.
yes,
But you combine it with RF?
combine with RF.
Okay.
Yeah.
Okay.
And another thing I just wanted to ask Dr. Rajkumar, for discogenic BMAC, how many sittings do you do, sir?
Only one.
Only one, yes. And when do you start feeling the results?
Takes around 3 to 4 months.
Oh yeah, that's one thing to drive you
Yeah.
crazy
Its
because the
cost
patients are
cost
going to keep
also
you very
very
busy.
high. That kit
Yeah,
is now it must be around 75,000 rupees.
yeah, that's
And sir,
true.
what
That's
are
true.
the indications for your this thing patients for discogenic
Dystonia
this thing?
pain for young patients with low back pain going around along the center of the spine. The typical, and on MRI also you see the typical.
Discogenic pain with HIZ, you
Yeah,
mean?
yeah.
So do
Okay,
you
contained disc.
do a diagnostic discography prior to thinking about doing a bima? Because it's a costly affair for the patient as well. So you cannot.
Can do, but it's better to avoid going inside the disc again and again. When the
Hmm.
big, when your diagnosis is very much clear, you collaborate with the MRI findings and the symptoms are, and these are usually the young patients with the, low back pain along this center of the spine. So diagnosis is, I mean,
So basically, the procedural counseling has to be
can
very,
do
very
it.
strong.
We can do it.
Yeah.
I
Yeah.
know you are doing a lot of it,
Yeah.
but
So what
we
I
avoid
think
because
is pre-procedural counseling is very important. Here you have to tell patients that you are going to be not very happy about taking the injection for around 2 to 3 months,
yeah, and
and
then
then only it's going
Dr.
to show you
Namrata was
results.
saying that a lot of pain and spasm post procedure.
Yes, yes, yes.
You are injecting it takes a lot of pressure to inject even couple of mLs of
MS. Yeah.
PMAC.
That's right.
It hardly accommodate any volume.
Yeah. Thanks.
Presenters, do you have any addition? I know they did put in a lot of effort to prepare these. Dr. Shveta, Dr. Nitika, any questions or any personal experience with PRP?
Ma'am, I've just used PRP for osteoarthritis. Recently, we are using that hyperacute serum in osteoarthritis. Basically, it contains more of anti-inflammatory factors as compared to the pro-inflammatory PR. In patients in whom we have we want to avoid the increase in the inflammation, so we can inject these biologics which are rich in anti-inflammatory cytokines like hyperacute serum. So
Do you
we have
prepare this
injected.
hyperacute serum?
Basically, there is autologous condition serum which is prepared after incubation for 6 to 8 hours.
Got it. There are special kits for it. Okay.
Yes.
Dr. Shweta, any
Shita, you are
personal
still in
experience?
AIIMS or you're done with your fellowship?
No,
Uh,
my experience with PRP is only in knee osteoarthritis. I have never used it in low back pain cases, but definitely from today's experience, what we have shared so much, I would like to use and see the results in a specific group of patients. I would also like to know if there is any specific, like if a setup or hospital has to buy a PRP machine, is there any suggestion what should be the standardization? Like any specific model or something like that?
There is no particular, I mean, everyone is using separate PRP machines, whosoever is practicing pain, that's getting it from blood bank is, I don't think is practice anymore anywhere. Most of us who practice PRP in
I get it from my blood bank.
sir is getting from the blood bank, okay.
But I think there is
Probably
a lot
soon.
of heterogeneity in PRP preparation, and probably that is the reason why results are varying.
That's there, yeah.
Results are, I mean, earlier when we started using it, we, by not actually me, but like as a pain physicians or the standardization wasn't there. So now people know, to which particular group of patients they should target. So that's why the people are started getting, and ultrasound guided, just, getting into that particular, seeing that tear, injecting right into that tear. So I think that is what improves and selecting young group of patients, early stage, not like that.
The type of machine, whether we are getting from blood bank or have a separate, that's not so significant
So Raj Sir said he's using from blood bank and he's getting good results. So I don't think that should make a difference, but it's just more comfortable if you have in your department and it's easier to do it.
Yeah.
What I personally feel about using PRP from blood bank is there is a lot of exchange of hands. When you ask the technicians to collect the blood and then he processes it, you are not very sure whether he's observing the correct, sterile precautions. I would be very, very jittery
Yes,
about
preparing and they are preparing for the orthopedics department, so they know